This podcast is sponsored by Zoll LifeVest. Zoll has continuously improved LifeVest for over 20 years, leading to a median real-world wear time of 23.4 hours per day and an AI-enhanced algorithm that delivers zero median false alarms at 90 days. The newest LifeVest garment is lightweight, breathable, and preferred by patients for its comfort. Learn more at lifevestinnovation.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. It is Dan Ambinder here, and we are super excited to be visiting Ann Arbor, Michigan, and hanging out with some amazing cardiology/CardioNerds enthusiasts to talk about some serious and informative cardiology. So today, to join us, we have Oyinkansola Osobamiro, Aishwarya Pastapur, and Rafik Issa. Team, why don't you go ahead and introduce yourselves?
Hey everyone, my name's Aishwarya, and I'm a third-year internal medicine resident here at the U of M. I just matched into cardiology fellowship at Northwestern University, and I'm interested in cath versus EP.
Hi guys, my name is Oyinka, and I'm a first-year fellow at University of Michigan, and I'm interested in either general cardiology with cardio-obstetrics or heart failure.
Hi everyone, my name is Rafik and I'm an intern here at U of M. I'm interested in cardiology, not sure of the exact subspecialty yet, but thinking about general cardiology, critical care, and EP.
Well, team, as you can see, we have an array of interests and an array of great people. So, team, why don't you take us to your favorite place in Ann Arbor, Michigan, and set the stage for us for our conversation about a patient.
Well, Dan, I personally love to visit breweries and restaurants around town. I especially love Holmes, which is one of the best breweries for sour beers and IPAs around here. It's a fan favorite.
I agree with Aishwarya. I think Holmes is great. In addition, I really enjoy going outside in Ann Arbor during the summer and floating down the Huron River or walking around the Nicholas Arboretum for some amazing scenery.
Yeah, I fully co-sign all of those recommendations.
All right, terrific. So let's get some sours, get some puckered up faces, and then go take a walk and kind of walk off those extra carbs and have a great conversation. So what case do you have in store for us today?
All right, Dan. So we have a woman in her 50s who's presenting to the hospital with dyspnea. Her past medical history is notable for stage 4 lung cancer with metastases to liver, bone, and brain. She also has history of previous saddle pulmonary emboli, as well as pericardial effusions and malignant pleural effusions. Her medications are notable for a DOAC for her prior pulmonary embolism, dexamethasone for her brain metastases, as well as her oral chemotherapy agent. Additionally, she's on mirtazapine for appetite stimulation, amitriptyline for chronic pain, and opioids for cancer-related pain. In her case, she's got a lot of contributing comorbidities that could make her feel more short of breath. Oyinkan, what's on your differential for her?
Well, Rafik, like you said, there are a lot of things that could be contributing to her dyspnea. In general, I wonder about infection, fluid, and blood clots, meaning pneumonia, pulmonary edema, or pleural effusions, and pulmonary embolism. For her, I would wonder about her tumor burden, the potential for recurrence or worsening of her pulmonary embolisms, increased pleural effusions, and of course, tamponade physiology. I'd want to ask her specifically about whether she's missed any doses of anticoagulation, if she's had any fevers, chills, or cough, or if she's had any changes in output from any drain she may have, and if she has any orthopnea or PND.
Thanks, Oyinka. What objective markers would lead you down those different pathways on your differential?
I'd be on the lookout for fevers and tachycardia, which would make me consider infection or pulmonary embolism more strongly. Rafik, can you tell us a little bit more about her presentation?
Absolutely. So for the past 5 days at home, she says that her heart rate has been increasing up to the 130s. She also has a pulse ox at home, and she knows her oxygen saturations were dipping down to the mid to high 80s. Otherwise, she hasn't noticed any fevers or chills. She denies chest pain, lightheadedness, no abdominal pain, and no changes in her bowel or bladder habits. On physical examination, she's afebrile, tachycardic to 121, and blood pressure 120/82. Generally, she's cachectic and appears chronically ill. On her cardiac exam, she's noted to be regularly tachycardic without any murmurs, rubs, or gallops. She has trace lower extremity edema. She's requiring 5 liters of oxygen via nasal cannula to maintain her saturations in the low 90s, but has normal workup breathing on that. Her lungs are clear to auscultation, and she has a Pleurex catheter in place for her chronic pleural effusion. neurological exam is notable for word-finding difficulties, which is her baseline after developing the metastases to the brain. She otherwise has no other focal deficits.
Thanks for that context, Rafik. With that oxygen saturation, tachycardia, and physical exam, I would definitely be worried about pulmonary embolism. I also don't think we can definitively rule out infection or pulmonary edema or an increase in her effusions. I would probably want labs including a trope, a chest x-ray, a TTE or transthoracic echo, an EKG to better understand her tachycardia, and probably a CTPE as well.
Excellent thoughts, Oyinka. Our ED had similar thoughts. With regards to blood work, they obtained a VBG, a CBC, a CMP, and high sensitivity troponins. On the venous blood gas, her pH is 7.4, PCO2 is 37, and her lactate is 2.8. Her CBC is notable for a white blood cell count elevated to 13.8, though this is stable from 13.3 a week prior. Her hemoglobin is 12.1, previously 13.2, and her platelet count is 73, previously 130. Her comprehensive metabolic panel has a sodium of 137, potassium of 4.6, BUN 38, and creatinine 0.83, with a glucose of 154. Her LFTs are within normal limits, though her alkaline phosphatase is elevated to 236, previously 204. Her INR and total bilirubin are within normal limits, and her initial high sensitivity troponin is 8, and the 2-hour repeat is 9. So that's a negative delta.
It's great to have that blood work back. She seems to have a slightly worse thrombocytopenia, though her remaining labs appear stable. Her alk is high, but could be explained by her liver or bone mets. I'm interested to see some of the imaging.
Definitely. I've got an EKG and some imaging here for you. So for her EKG, it shows a normal sinus rhythm with left atrial enlargement without any significant SC or T wave abnormalities. However, it is noted to have low voltage QRS complexes. As far as imaging goes, a CTPE was obtained that showed scattered and acute pulmonary emboli in both the upper and lower lobes. She also had an enlarging pericardial effusion, and the imaging redemonstrated a similarly sized right lung mass and pleural effusion with a drainage catheter appropriately placed. She also had abdominal imaging with a CT abdomen pelvis, which showed distal colonic mucosal enhancement, as well as a questionable small bowel intussusception without any dilation, and had progression in her osseous metastatic disease. The ED provider performed a bedside echo, which showed a large pericardial effusion with evidence of diastolic right ventricular collapse, an RV to LV ratio of 0.95, with normal interventricular septal positioning. They astutely measured the pulsus paradoxus, which was 18. Oinkan, how do you usually measure a pulsus paradoxus?
Great question, Rafik. And honestly, I fully began to understand this as a first year fellow. So there's a lot of ways to measure a pulsus paradoxus. A pulsus paradoxus, it essentially arises due to restriction, which prevents the heart from filling with blood adequately. As a result, when there's negative interthoracic pressure with inspiration, the blood instant backs up, which leads to a decrease in forward flow and a drop in systolic blood pressure. The standard way to measure a pulsus paradoxus is to check with a manual blood pressure cuff. As you deflate the cuff, you will hear corticoff sounds during expiration, which will be your first systolic pressure. You'll continue to deflate the cuff, and then you will soon notice corticoff sounds with both inspiration and expiration. That's your second systolic blood pressure. The difference between the two is the pulsus paradoxus, and a pulsus greater than 10 is abnormal. This can also be obtained by palpating the radial pulse or monitoring the arterial waveform on our arterial line during inspiration and expiration. Pulsus paradoxus can be caused by various conditions that cause a restrictive physiology, including cardiac tamponade, RVMI, restrictive cardiomyopathy, really bad asthma or COPD, severe untreated OSA, pulmonary embolism, tension pneumothorax, and bilateral pleural effusions.
That was fantastic. Thank you so much for going over that, Oinkan. I know this can be a topic that can be really confusing. Let's dive back into the case. For our patient, due to the concern for cardiac tamponade with pulsus paradoxus and elevated lactate, she's admitted to the cardiac ICU. She receives 2 liters of IV fluids, and due to concerns for other types of shock that may be contributory, she started on antibiotics with IV vancomycin and cefepime, while cultures are pending. Finally, she's continued on anticoagulation with IV heparin due to concerns that she's developed acute emboli despite being on systemic anticoagulation in the outpatient setting. With cardiac tamponade as the leading diagnosis on the differential, the plan is made to proceed with pericardiocentesis and drain placement. Before we hear more about her case, Aishwarya, can you share more information with us about the indications and contraindications for pericardiocentesis?
Of course, Rafik. In terms of indications, there are a few. In patients who are hemodynamically unstable or in shock, the procedure is considered urgent or emergent because decompression of the pericardium will restore normal ventricular filling and appropriate cardiac output. In the absence of shock or hemodynamic compromise, indications include symptomatic moderate or large effusions, effusions not responsive to medical therapy, concerns for bacterial or neoplastic pericarditis, or a large chronic effusion of greater than 20 millimeters lasting longer than 3 months. There are no absolute contraindications to the procedure if there is concern for tamponade or shock. Otherwise, aortic dissection or free wall rupture after myocardial infarction are relative contraindications due to the risk of exacerbating the dissection or the myocardial rupture with rapid restoration of systemic arterial pressure. Relative contraindications include coagulopathy, the use of anticoagulants, and thrombocytopenia less than 50. Finally, regarding major complications, there is a risk of cardiac injury, laceration of the coronary arteries or intercostal vessels, puncture of the abdominal organs or the peritoneal cavity, pneumothorax, pneumopericardium, ventricular arrhythmias, and pericardial decompression syndrome. Getting back to our case, we have a woman in her 50s with a past medical history of stage 4 lung cancer with metastases to the liver, bone, and brain, previous SATR pulmonary emboli, as well as acute scattered pulmonary emboli, pericardial effusion that has been chronic in the past, and malignant pleural effusions, presenting with concern for tamponade physiology. Oyinka, do you mind sharing her procedural course with us?
Of course, Aishwarya. And just to take a step back and give some context, this is a really sick lady with multiple comorbidities that are contributing to her presentation. So for her pericardiocentesis, we paused her heparin for a few hours periprocedurally. Then in a pericardiocentesis, what happens is that we place a needle into the pericardial space and we essentially measure the pressures in the pericardial space. For her, she was found to have a pericardial pressure of 20 millimeters of mercury. For context, because I didn't know this really before being a fellow, that's super high, right? If you think about it, your normal CVP should be 5 to 10 ideally, and your pericardial pressure is sort of this gradient with which allows venous return to your heart. And so if your pericardial pressure is so high, you're going to have impaired venous return to your heart. This procedure went well. They were able to drain 750 cc's of serosanguinous pericardial fluid, and a drain was placed with improvement of her hemodynamics following there for any additional sequelae of fluid. After this, they were able to measure the post-pericardiocentesis pressure just to confirm our result, which was 6 millimeters of mercury. She is returned to the CCU after her procedure and her heparin is resumed. Rafik, can you share what happened next with the case?
So thank you for going over that, Oyinka. So when she first returned from the procedure, she was actually doing fairly well, and her vitals were stable. Her mean arterial pressures were stable in the 70s. However, 2 hours later, she suddenly starts developing several concerning changes in her vital signs that seemingly come out of nowhere. Initially, her oxygen requirement starts to increase from 8 to 12 liters, and then her mean arterial pressures start to rapidly plummet down to the 50s. And ultimately, this hypotension is sustained, and she starts requiring norepinephrine drip for hemodynamic support, going up to the maximum dose of 1 mic per kg per minute. While this was ongoing, it was also noted that she was having increased sudden output from her pericardial drain, as much as 400 cc's of frank bloody output in the drainage bag. At this point, Aishwarya, what's on your differential for her clinical decompensation?
Yeah, Rafik, thanks for going over that. In terms of my differential for her, there are a few things that I have in mind. With her sudden decompensation after a procedure just 1 to 2 hours ago, I would definitely keep post-procedural complications in mind. Her pericardial drainage bag had sudden bloody drainage, which, in conjunction with her worsening hemodynamics, makes me worry about something like an RB perforation, cardiac injury, or coronary laceration, like we discussed earlier. Her heparin is held due to this drainage and concern for these potential complications. There's also the potential for reaccumulation of her pericardial fluid with drain malfunction or blockage, causing worsening of her tamponade physiology. And I also worry about increased PE burden, though this is less likely since she was fully anticoagulated except for a few hours periprocedurally, and her PE burden had been pretty low on admission. Oyinka, can you share what happens next?
Of course. So to evaluate for those complications you discussed, Aishwarya, we performed a stat bedside echo. On our evaluation, we did see trace remaining pericardial effusion, but no signs of ventricular perforation. Surprisingly, we noticed a severe RV dilation and dysfunction with a positive McConnell sign and a hyperdynamic LV. At this point, our highest suspicion is that this is due to our PE burden, but we have no CT imaging to guide this. So we're really concerned essentially about obstructive shock physiology from her PEs. Okay, so we contact our multidisciplinary team that focuses on massive or severe pulmonary embolisms for guidance. For her specifically, systemic thrombolysis was very high risk in the setting of her known brain metastases. Similarly, catheter-directed thrombolysis would be difficult because the previous CT imaging showed scattered PEs rather than a central one to target. Ultimately, she would need a repeat CTPE to determine her clot burden if there was a specific embolus to target. Given that she was requiring increasing amount of vasoactive medications for blood pressure support, it was felt that she was not stable enough to be taken down to the scanner for a CTPE. At this time, we had a goals of care discussion with the patient's family. Just to kind of paint the scene, the patient is incredibly uncomfortable at this time. She's in a lot of pain, and she had previously been quite clear in saying that she would not want to be resuscitated should she die. After discussing the patient's worsening hemodynamic compromise and our limited evaluations to treat her or her shock physiology, the decision is made to pursue a comfort-focused approach. She ultimately passes away a few hours later. Our team, however, remains really perplexed. What caused this hemodynamic effect paradoxically after the pericardiocentesis? It felt odd that the pulmonary embolisms could so significantly worsen in just 2 hours, particularly because she had only a limited amount of time where she hadn't seen anticoagulation. So we were confused. Was it really just holding the heparin for that short of a duration the trigger?
These are all really great questions, Oyinka, and that's what led us to read more about the complications after pericardiocentesis. Specifically, one that we discussed earlier, known as pericardial decompression syndrome, stood out to me. Pericardial decompression syndrome is a rare, life-threatening syndrome occurring in about 5 to 10% of cases where you have a paradoxical worsening of hemodynamics after pericardial drainage. It has varying presentations from pulmonary edema to cardiogenic shock that occur a few hours to days after a successful pericardiocentesis. There are a few hypotheses, though the true mechanism is not well understood. One theory is that there is a paradoxical hemodynamic derangement due to rapid increase in the venous return to the RV after the pericardiocentesis, resulting in expansion of the RV and potentially septal deviation of the LV. The LV subsequently experiences decreased preload while still facing the increased afterload that the body had developed as a compensatory mechanism to obstructive shock, or in this case, the use of pressors, ultimately leading to decompensation. Another theory suggests that increased intrapericardial pressure may impair coronary perfusion, leading to myocardial ischemia. On pericardiocentesis, there's myocardial stunning with increased demand due to increased venous return and increased cardiac output. And a third theory suggests that withdrawal of sympathetic activation after drainage of pericardial fluid triggers cardiovascular collapse. Risk factors for PDS include the presence of a chronic or malignant pericardial effusion, rapid removal of fluid, and underlying cardiac dysfunction. Management is largely supportive with respiratory and cardiovascular support. Most cases improve within 24 hours, and prevention may involve removing smaller amounts of fluid, just enough to resolve the shock physiology during the initial pericardiocentesis, and then leaving a pericardial drain in place to remove the remaining fluid slowly.
Thanks for that, Aishwarya. I want to take a step back to highlight how complex this case is, because I don't want everyone to fear pericardiocentesis due to her rare post-procedural course. This patient was incredibly sick. Her specific comorbidities, including her prior pulmonary emboli and pleural effusions, likely caused a component of underlying chronic pulmonary hypertension. After pericardiocentesis, her underlying physiology and right ventricular dysfunction were unmasked, which led to the collective syndrome of PDS. Ultimately, the wishes of the patient and her family were respected, and she passed peacefully. In the future, we should consider PDS when patients have sudden decompensation after pericardiocentesis, particularly patients who have these unique risk factors.
This was a very educational case for me, both from an intellectual level, but also as well in terms of managing family dynamics and seeing how having that earlier discussion with the family about the patient's wishes was really helpful in this case. I think in terms of the clinical pearls for this case, there are several really useful things to take away from this case. First, in terms of the presentation of tamponade, so diminished heart sounds, low voltage EKG with electrical alternans, elevated JVP, and elevated pulsus paradoxus are important findings that could be suggestive of cardiac tamponade. Second, McConnell sign on the echo is strongly suggestive of RV failure and pulmonary hypertension, potentially due to a pulmonary embolism, as was in this case. Thirdly, mechanical thrombectomy for PE is not feasible if the embolism is diffusely scattered without a central lesion for them to target. Fourth, for patients who experience a decompensation following pericardiocentesis, there is a wide differential, including perforation, tamponade reaccumulation, or potentially PDS. And when possible, it is important to avoid draining more than 1 liter of pericardial fluid at once to minimize the risk of PDS due to the body's mechanisms of adjusting to the pericardial fluid over time, and then the sudden withdrawal potentially precipitating the syndrome.
Team, this was a really, really important case to highlight, and it has many pearls, as Rafik just pointed out. But you gave it your all for this patient, and we are all so glad that she was in your care. You honored the patient's wishes when it was time to pursue comfort and palliative cares like the patient had delineated beforehand, which I think was very helpful for this case. But at the same time, the team pondered and really investigated and thought about what would ultimately cause this patient to have such a surprising hemodynamic downturn after the pericardiocentesis, which we thought would correct her hemodynamic compromise by removing that pericardial fluid. Again, that pressure around the pericardium was really, really elevated. So when the patient's hemodynamics did not respond in the way that we would have expected, we had to go back to the drawing board and think about how and why this could have happened, and also potentially apply that to patients that we meet down the road. So thank you so much for bringing this really important and sobering case to our attention and identifying pericardial decompression syndrome as a potential etiology of the patient's clinical post-pericardiocentesis course. But thank you so much for being here today.
And lastly, for a word from Dr. Brett Wanamaker, who is an interventional cardiologist and who is our CCU attending at the University of Michigan. He has excellent insight into managing complex patients like this, and for us residents and fellows, we always enjoy working with him. Dr. Wanamaker, the floor is yours.
Hi, everyone. My name is Brett Wanamaker, and I'm an interventional cardiologist at the University of Michigan. It's an honor to be an expert discussant on pericardial decompression syndrome, where we're talking about the paradoxical worsening of a patient's hemodynamics and ventricular function following the evacuation of a significant pericardial effusion. So this can be manifest as shock after the procedure, or sometimes worsening of the patient's respiratory status with hypoxia or pulmonary edema. This is a really interesting and important topic, I think, for a number of reasons. First, it's thought to be relatively rare, and there aren't actually good data on the prevalence of the condition. It's probably under-recognized and underreported, which doesn't help. So most of the information that we have on this syndrome is from case reports and aggregated case series. Psychologically, for the interventionalist and the critical care physician and the cardiologist, this can be really frustrating and a bewildering thing. Pericardiocenteses are one of the most satisfying procedures that we do in the lab, especially when a patient is in frank tamponade, because we often get immediate positive feedback as the patient rapidly comes off pressors, improves their perfusion, and is pulled out of shock in cases of true tamponade. And so when we consent patients or their families for centesis, the risk-benefit conversation is obviously highly tilted toward benefit. In pericardial decompression syndrome, the patient exhibits the opposite of the expected resultant trajectory, and so that's really a violation of our expectations. The first point of emphasis is that this is a relatively uncommon issue following pericardiocentesis. So if you do have a patient who's experiencing hemodynamic issues or respiratory difficulty after a procedure, one should really think about far more common causes, with the most likely being a procedural complication. The complication rate of an elective pericardiocentesis is overall really low in experienced hands, especially using ultrasound and fluoroscopic guidance, but this can certainly increase when the situation gets more urgent or in truly emergent settings, such as like a bedside tap, for example. Complications include laceration of the myocardium, especially when we're thinking about vulnerable thin-walled structures like the right ventricle or atrium, or damage to another vascular structure. And usually, this would be confirmed by brisk continued hemorrhagic output from the pericardial drain, but not always. Other complications to think about are a pneumothorax or hemothorax, acute ischemia from damage to a coronary artery, again related to a procedural issue. So if there were anatomic or other patient features that made the case really difficult, or if multiple sticks were required, the index of suspicion of a procedural complication certainly increases. But if that's been ruled out and we see clinical features that are consistent, it's time to think about pericardial decompression syndrome. Many cases of pericardial decompression syndrome actually don't happen immediately in the instant that the patient's in the cath lab, but instead are delayed by several hours after drainage of the effusion. Sometimes actually after that initial period of hemodynamic improvement with the draining of the effusion. There have been case reports of the syndrome occurring up to 48 hours after the procedure, so it certainly doesn't always need to be an immediate phenomenon. There's no specific underlying etiology of the effusion that seems to favor development of the syndrome. Thought that some element of effusion chronicity is required to place the patient at risk for decompression syndrome. So in other words, if it was an effusion that developed acutely, such as something from a procedural complication earlier in the day, those patients don't seem to go on to pericardial decompression syndrome. The exact pathophysiology of pericardial decompression syndrome is not really well understood, but there are a number of potential hypotheses. One thought is that rapid hemodynamic stressors can occur when a large amount of pericardial fluid is removed in a tamponade situation. So with tamponade relieved, there can be a sudden increase in venous return and right heart filling, which then may distend the right heart at the expense of the left heart, which itself is also coping with a sudden increase in pulmonary venous return. There's some thought that after the left ventricle has had a low end diastolic volume for such a prolonged period of time, it can have a temporary difficulty maintaining contractility and coping with a higher end diastolic volume for a temporary period of time. So that left ventricle has not seen end diastolic volumes like that for potentially hours to days, and then the sudden filling may stun it. At the same time, the patients usually have quite high systemic vascular resistance, so the afterload for the left ventricle is really high as these patients are really clamped down, which was one of their compensatory mechanisms in the setting of tamponade. Another thought is that very high pericardial pressures actually inhibit coronary blood flow and result in global ischemia that can cause a transient myocardial stunning and diastolic dysfunction. And then finally, there's this idea that when we drain the pericardial space, there's an imbalance in the autonomic nervous system that occurs with a rapid withdrawal of sympathetic stimulation. And so there are some people that believe that patients with pericardial decompression syndrome actually exist along the continuum of patients with stress cardiomyopathy. And draining the effusion allows for one or both ventricles to become distended with venous inflow, and this sort of unveils the stress cardiomyopathy that they were already having in the setting of their effusion and tamponade. But the bottom line is that we really don't know. So the case that was discussed, and much of the discussion focuses on pericardiocentesis, but it's worth noting that this can also be observed after a surgical pericardiostomy as well. So because pericardial decompression syndrome is rare, it can be difficult to predict and prevent, especially since centesis is almost always urgently indicated in many of these patients. Occasionally, we're asked to consider centesis in a patient who has really poor reserve. You know that they have baseline left ventricular or right ventricular dysfunction or both. And sometimes the cases are equivocal. So in equivocal cases where the diagnosis of tamponade is uncertain, our group finds it useful to perform a right heart catheterization to support the diagnosis, especially if the patient's frail or the centesis may be very anatomically difficult, or there's other patient factors that might lend themselves to elevated procedural risk. It's always worth remembering that signs like pulsus paradoxus and other clinical and echocardiographic features of tamponade can also be seen in the context of other conditions that have large intrathoracic pressure swings, such as extreme respiratory distress in the setting of a COPD exacerbation, for example. Another strategy is to take a sort of paced measured approach during a pericardiocentesis in terms of the fluid that we drain. So this would mean placing a pericardial drain and then releasing a moderate amount of pericardial fluid to relieve the tamponade physiology, and then observe the patient for their hemodynamic response. We're draining just enough to relieve tamponade. And then with the drain in place, there's always the option to remove additional fluid at a later time, either in the cath lab or in the unit in the slow and controlled setting. At our institution, we have a robust population of patients with advanced pulmonary hypertension and significant right ventricular dysfunction. So not infrequently, we'll see these patients present to the hospital in sort of a subacute decompensation, and they have a moderate to large pericardial effusion. And that's, in general, a negative prognostic sign. But in these situations, it can be difficult for us to parse whether their clinical status is due to volume overload and further decompensated right heart failure, or is the effusion contributing, or both. And we're very, very wary about large volume pericardiocentesis in these patients because they're so clinically fragile. The diagnosis of pericardial decompression syndrome is one that is usually made at the bedside, first by ruling out a peri-procedural complication, other potential contributors. And really, bedside echocardiography is essential because it can verify that the effusion has not reaccumulated, and it will also often tell you that there's new ventricular dysfunction. These patients almost always have a fairly recent baseline echo for comparison that showed their effusion that led to the diagnosis of tamponade or significant pericardial effusion. So you have a fairly recent echo to compare to. In the case presented, the patient had new RV distension, severe RV dysfunction, McConnell sign, which was not at all present earlier in the patient's course. Isolated pulmonary edema without obvious ventricular failure has also been described, but most often you'll see significant dysfunction of one or both ventricles that's new. And you can see isolated LV dysfunction, isolated RV dysfunction, or biventricular dysfunction. They've all been described. The treatment of pericardial decompression syndrome is aggressive supportive care, as we would any patient with cardiogenic shock in the setting of cardiomyopathy. So it's important to understand if the patient has left ventricular predominant, right ventricular predominant, or biventricular dysfunction. And so sometimes a right heart catheterization, of course, your bedside echocardiogram is going to be helpful in this regard to understand how to treat them. Many cases may require mechanical circulatory support or even ECMO, depending on their clinical presentation. The good news is that their ventricular dysfunction usually resolves relatively quickly. So this is a reversible phenomenon over a period of days. And knowing that it's reversible in a relatively short time course can be helpful when you're discussing with patients and their families about escalating care. And in most cases, there aren't any long-term sequelae, provided that the patient can be supported adequately through the episode. In the case presented, however, further aggressive care was not in line with the patient and family's goals, given ongoing suffering, debility, and widespread metastatic cancer. In summary, pericardial decompression syndrome is a rare but important phenomenon to keep in the back of your mind when you're dealing with patients who present with significant pericardial effusions. It's poorly understood and difficult to predict, but in patients who are known to have a baseline cardiomyopathy and especially severe right ventricular dysfunction, it makes sense to exercise caution with large volume pericardiocentesis and really know that this is a potential. Knowing about this phenomenon and keeping it on your differential is essential to caring for patients with pericardial syndrome so you can recognize it and know what's going on and support your patients through it. It's been an absolute honor and a pleasure to discuss pericardial decompression syndrome as part of this CardioNerds case presentation podcast. I want to give a big shout out and go blue to our stellar team at the University of Michigan Frankel Cardiovascular Center. And I want to thank everyone for listening and wish you all good luck on your journey.
Thank you for tuning in to this CardioNerd episode. The audio and editing for this episode was performed by me, Atefeh Ghorbanzadeh. I'm an intern in CardioNerd Academy House in Pullman and a research fellow at the Mayo Clinic. I invite you to check out our website for show notes and references. If you find this episode informative, please consider subscribing to CardioNerd on your favorite podcast platform and leaving us a review. It really helps us spread the word for our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views and expresses on our show and site do not reflect the opinion or policy of our employers. All CardioNerd content is planned, produced, and reviewed solely by CardioNerd. Stay tuned for more engaging conversation and exploration on our upcoming episodes. And now, it's time to make like S2 and split.